it's a pleasure to be here and to have a chance to talk with you all about an issue that I have been very interested in. If I can share a little bit of our experience with you. I'm going to talk today about women of color and myositis, but this really could have been people of color. It's not just for women, it's men also. And I think that it really speaks to some of the unique problems that we've identified in terms of getting everybody who needs the amount of care access to care. And one of the things that I noticed as I looked around at this meeting is that there are not as many people of color here as I would expect, given the number of people who are affected by it. So I hope that one of the things I'll ask you to do is when you go home, in your clinics, in your support groups, to encourage people to reach out, encourage people to become involved, because I think that, as I'll tell you, my story is a very personal story as to why I became interested in this. And a big part of it was seeing who it was that was not being paid attention to with as much care as I felt needed to happen. So let me tell you a little bit about what I'm going to do. And I want to just start off by saying, feel free to ask questions. My purpose for being here is to answer your questions. And so I have only a couple slides that I was going to go over, and I want you to tell me what you would like to know or how I can help you. I want to be very clear about what we do know and what we don't know. And unfortunately, a big part of what I'm going to talk about is what we don't know. Okay, so I want you to understand what it is, where we are, or where we need to go. And I also want you to understand that the way we can get to the knowing part is through research. And so we try very hard to recognize the things that need to be answered and approach those through our research. But research only happens if our patients are engaged. And I'm going to give a talk that is partly adapted from a webinar that I gave with my colleague Shalonda Johnson. Shalonda was one of my trainees who's now at Penn, and Shalonda and I started working on understanding some of the differences of people of color who have myositis and European Americans who have myositis. And I'm going to talk a little bit about what we found in this. So what I want to start off with is I want to tell you who I am, because I am probably the most unusual person who's here at this meeting, because I'm actually a lung doctor. I'm not a muscle doctor, I'm not a joint doctor, I'm not a neurology doctor. I'm somebody who just takes care of patients who have lung disease. And I work at Johns Hopkins in Baltimore, Maryland, and unfortunately Baltimore has been in the news lately. If any of you looked at your Twitter feed or looked at the news, we've been in the news a little bit. It hasn't been real flattering, but unfortunately we recognize that that's not the Baltimore we live in. But what I'm going to tell you about the Baltimore we live in is that the state of Maryland is 60% white and 30% black approximately. The city of Baltimore is the reverse. We're 60% black and we're 30% white. And so as a result, we have had the incredible opportunity of working with a lot of people of color in our clinics. And because we live in an area where there's a larger number of people of color, we've actually made observations that weren't possible for folks who lived in areas where they have smaller populations of, they have less populations of color. We can ask them if they can turn down a little bit. So I've been at Hopkins taking care of patients with interstitial lung disease for about 20 years, which is really hard to say out loud, but it's actually true. And although interstitial lung disease affects people of all ages and backgrounds, what I realized early on in my career was that many of the patients that I saw who were the sickest were actually my youngest patients, not my oldest patients, women and people who were black. And because of that, I became very interested in why it was these patients were getting interstitial lung disease. And that's actually what led me to start my career doing research on myositis-associated interstitial lung disease. So pretty much for the last 20 years, drawn in by my patients, this is what I've been thinking about on a day-to-day basis.
And so what I wanted to talk about a little bit is, why would we even think about background as being an influence on the development of myositis or really any other disease? And I know that you probably have heard or read that some diseases are more common in different ethnic groups or different racial backgrounds. And I realize it might not be obvious why we do that. And so I wanted to just start off with the general topic of, why do we think about this? And so when we're trying to understand really either health or disease, one of the things we do is we gather this group of data that's called demographics. And demographics are really things that are just descriptors about you. How old are you? What's your sex? What's your race? Where do you live? How many years of school did you go to? Maybe what's your income? And the reason we do that is because it just gives us some categorization for understanding what kind of people we're seeing. Are we seeing mostly older people? Are we seeing mostly younger people? It tells us something about a predisposition. But what you can realize is that some of these are biological variables. So your age and your sex are biological variables. That's when you were born and what sex you were. Although your gender identity may be different, your sex was determined when you were born. But the rest of these, including race, are actually called social variables. So although we can look at each other and somebody might look at me and say, well, you look like you're such and such a race, that's actually a social construct. So it's very hard at a superficial level to look at people and say, I know what race you are. And you'll find out that that actually creates some problems when we're trying to understand some of these. But what we do is we ask people, when you think about yourself, what race do you identify as? Do you identify as being Hispanic? Do you identify as being Asian? Do you identify as being black? Do you identify as some other racial group? So we ask people to tell us what they think that they are. But that is actually just a social construct. Now, why we do this, and so how we think about this, and what starts us from this, is that we might say, and I'm going to give you an example that's unrelated to myositis. We might say, so older people are at greater risk of developing Parkinson's disease. Ooh, this is going to be annoying if it does it the whole time. Older people are at risk of developing Parkinson's disease compared to younger people. So that doesn't mean that all older people will develop Parkinson's disease, nor does it mean that no young people will develop Parkinson's disease. So what we're really talking about is, on average, what is the likelihood that you'll develop a disease? And so when we talk about generalizations about people of different race or people of different ethnicity, we're talking about a general idea. We cannot predict for an individual, okay? So I want you to be clear that what I'm going to talk about is general. It's not necessarily, this is what's going to happen to you. The other thing is that it doesn't really explain why that relationship exists. So for instance, we don't know why being older might be a risk factor for Parkinson's disease. And so some of the associations I'm going to tell you about, we don't know why they happen. So here's what we have observed. This is what we can tell you. I can describe this to you. I can tell you that there is a form of myositis called inclusion body myositis. This form of myositis is much more common in white men than in white women, black men, Asian men. It is much more common in white men. In contrast, if you look at polymyositis and dermatomyositis, those are much more common in women. So fundamentally, just by describing it, I know that it is, if you're a man and you come in and you're older and you're white, this is a more likely diagnosis than this is. If you're young and you're a woman, and particularly if you're black, I know that this is the much more likely diagnosis. Now, there are certain features of polymyositis and dermatomyositis. So those are names we give things, but in reality, there are a variety of different ways that these present. Some people get muscle weakness. Some people develop a rash on their skin. One of the features of myositis is actually involvement of the lung. And this, what we call interstitial lung disease, or ILD, is more common in black patients than in white patients. That is just what we've observed. If we take a group of patients who have interstitial lung disease, there is a much higher percentage of black patients in that population than would be predicted by the number of people, the races of our patients who show up in clinic as a whole. So there is something which makes this more common in people who self-identify as being Black or African American. Okay, so the very logical next question is why? Why should this matter? What is it about these descriptors, whether it be age or race or other things, that makes one person more at risk? Well, the answer is we don't actually know, and we think that it's a very important point that we have to figure out. So it could be related to what we consider biology. So I said that IBM is more common in older people. Well, when you age, it leads to changes in the cell, and maybe that's what predisposes people to develop specific diseases like IBM. We certainly know that things like Alzheimer's and Parkinson's disease are much more common in older people. So we think that aging clearly has some factor to it. Being or male or female, so I told you that men are more likely to get IBM and women are more likely to get polymyositis or dermatomyositis. Well, those clearly are also biological. So there's hormones that could be involved. So maybe female hormones or male hormones push the biological clock or the biological processes in one direction or another. The other thing is that genetic differences may have an impact on risk, and that's one of the things we're thinking about with regard to people who are of African ancestry, which we tend to call in the United States either African Americans or Blacks, and people who are of European American ancestry, who we typically describe as being white. Okay? So we wonder whether there are some genetic variations that may also underlie those self-identifications of what our race is. But the thing is that this is really complicated because there are also a lot of environmental factors that could be involved. So for instance, at least historically, men used to smoke more than women. So maybe it's not being male, maybe it's smoking that's the risk factor. Men often worked in industrial workplaces more than women did. This is, again, historically. So maybe some of the things that we identify as being related to a person's sex really have to do with some of the other things that went along with it. Certainly, nutrition is a big issue, and so we don't know whether some of the things we identify are related to a nutritional difference in the way people eat or in the pollution that they're exposed to, or even the stress in a person's environment. So sometimes what we think superficially is associated with one thing may be actually associated with something else. Okay, so that's hopefully to set up what I'm going to tell you now, which is that what we do know is that people of color with myositis have, on average, delayed diagnosis. They have very different disease impact, and they have a very different prognosis. Okay, so now I'm going to try to break that down and try to explain each part of that. Okay, so why is the diagnosis delayed in people of color? So firstly, just think about myositis. It's a very rare disease. It's supposed to be about 1 in 100,000 people per year. So that's a fleetingly rare disease. And I'm sure many of you know that it took 2 or 3 doctors before they figured out what you had because it's such a rare disease. And because it's rare, doctors don't know that much about it. So they probably heard about it in medical school, but many doctors will only see 1 or 2 cases of 1 or 2 people who have myositis in their whole careers. So when you're that one person who walks in, if you don't look exactly like things looked in the book during medical school, they may not know that. And because the symptoms can be very subtle, it can often be really hard to figure out what's going on. Many of my patients went to their doctors many times to say, hey, you know, I'm feeling weaker, I'm fatigued, maybe I've got a funny rash on me, maybe I feel a little short of breath. And it took a long time because those were very subtle changes for the doctors to recognize what it was. The other thing is that these can resemble other autoimmune diseases. So I have many patients with myositis who were originally diagnosed with something else. So maybe they went to their doctor and they were told they had lupus, or maybe they had rheumatoid arthritis, or maybe they had something else, or scleroderma. So sometimes getting to the right diagnosis can take a while just because it's kind of hard to figure it out. And then depending on what your first symptom is, if you have mostly breathing problems, the first person you might have seen is a pulmonary doctor. And I would like to say that most pulmonary doctors will recognize dermatomyositis, but the reality is they don't. It's a very, very rare disease, especially if you're a lung doctor. If you were first developed joint pain or skin disease, the first person you might have seen was a dermatologist. I have plenty of patients who got diagnosed with some other skin disease like psoriasis or eczema or whatever until they had this happen repeatedly, and then it became obvious that it was dermatomyositis. So these are all reasons why in general it's difficult to be diagnosed. Now, if you add on top of that things that are specific to people of color, well, I have to tell you that when you look in those medical textbooks and they show you the classic picture of the person with dermatomyositis, it's always a person who is white and has very pale skin. And the appearance of the skin changes is very different if you have dark pigment. So this is a patient who I see in my clinic, and I can tell you that she was seen by 2 or 3 doctors who did not recognize that she had features of dermatomyositis. And that was because it doesn't look the same when you have pigment. And unfortunately, there have been very few publications on specifically looking at skin changes in people of color. That's one of the things that Dr. Johnson and I are trying to work on, is to try to make that more understood for people who are seeing patients. Now, the other thing that is different is that the antibody markers that patients of color get are actually somewhat different. Although I know that there are some of you in the room who have JO1, there are probably people in the room who don't have JO1, and those other antibodies, things like PL12 and PL7, which are very commonly associated, are very common in our African American population and are associated with lung disease. For a long time, we could not test for those. You had to go to a specialty lab to get it tested. One of the very best things that's happened since I started doing this is that we now have the opportunity to test for those antibodies routinely, and a lot more patients are being picked up because of it. So these are a couple of the reasons why we find that there's a delayed diagnosis. Now, I'm going to go on and talk a little bit about disease impact unless you all have questions about that. I'm certainly happy to entertain any questions. Okay, so what does it mean? If I say that you have a difference in disease impact based on what your race is, well, it turns out that if you have autoimmune myositis, that is, if you have polymyositis, dermatomyositis, it is more common if you're Black. And that's something that's pretty shocking. If you look around here, you would not realize that the majority of patients who have this, or that proportionately more patients of color have it. Please.
Has there been actual research done on this?
Yes, absolutely. And that's part of what we're trying to do. It's a complicated situation, and part of it has to do historically with who has done most of the research on things like myositis. Most of the research on myositis originally came from England, and they have very small minority populations. And in the United States, a lot of the research that was done came from the Midwest, where again, you have very small minority populations. And so it really required having a couple centers like Hopkins, University of Alabama, Vanderbilt, where we actually had larger African American populations to recognize that this was what the pattern was. The other thing is African Americans tend to be younger at diagnosis. So we are more commonly seeing people even down into their late teens who are presenting with myositis. And that's something I think that has really surprised a lot of doctors. It's just not the age category we thought of. In whites, it tends to be a little bit later, 40 to 60, so we're seeing a much younger population. We find that lung involvement is both more common and more severe in African Americans with autoimmune myositis. So what that means is that when people come into our office, the first time they visit us, their lung functions, their measures of how well their lungs are doing is lower if they're African American than if they're European American, if they're white. And so what that means is that in general, patients are presenting younger and sicker. Unfortunately, and so one of the other things is that we think that both African Americans and Hispanics actually have unique genetic factors that are associated with autoimmunity. Now, this is something that it's not unique to just myositis. We know it's true in scleroderma, rheumatoid arthritis. We know it from issues with renal transplant. Kidney transplant is much more difficult, has a higher failure rate, and it's because there's differences in the way our immune systems are historically how our immune systems were developed and some of the markers that the immune system uses. So what that means is that the risk factors that are present in people of color are going to be different. And we are working, actually Dr. Johnson's working now to analyze a very large cohort, one of the largest cohorts of African American myositis patients, to try to be able to identify exactly what markers, what genetics cause that increased risk of disease. And hopefully as we understand that, we'll be able to understand what are the things that have actually led to some of these changes that we see, or the differences that we see when we see patients in clinic.
I have a question.
Yes, ma'am.
What's the difference in the autoimmune myositis and the IBM?
Yeah, so inclusion body myositis, although it's included in the idiopathic myopathies, it tends to be less of an inflammatory disease and a little bit more of a degenerative disease, and it tends to affect men more than women and whites more than blacks. That's not to say that you can't be black and a woman and have it. It just means that in general that's what we see. And so it seems to be a little bit of a different disease compared to like polymyositis and dermatomyositis, which sort of cluster together. IBM is almost like a little bit off on its own, being a slightly different disease. Okay? All right, so let's talk about what this means in terms of prognosis. And I think that this is a big part of it, because you know, if you walk in the door and you're sicker and you're younger, but everything goes great, then it makes less difference. Unfortunately, we know that women who are non-white, that is black and Hispanic women with dermatomyositis, have much greater hospitalization rates and longer length of stay. Okay, so why is that? Well, one might be that you get into the hospital and nobody knows what you have. They don't recognize your rash. They don't realize that you're at particular risk of developing this disease. Maybe your symptoms are a little different than the other patients that they've seen with this disease. So as a result, this is a big issue. Patients spend a lot longer in the hospital and they get hospitalized more frequently. Okay, so unfortunately, women of color have higher mortality rates, and that's a very big issue for us. So it is twice as high as all comers, and it's 4 times the mortality rate of European American men who have the lowest mortality rate. So that, I think, is a real call to arms. You know, this is not just a disease that affects people and gets them at a younger age. It's got a very significant mortality related to it. What that tells me is we need to be spending a lot of time and energy focusing on how to change those numbers. We know that non-white women, that is women of Hispanic or African American origin, that are age 15 to 34 are 3.5 times more likely to die than European American women. So this is a difference that is affecting our youngest patient population. This is affecting teenagers, women who are in childbearing years. And again, this is really a call to us, to every one of us, to try to change this situation. I think that the first thing is recognizing it. It's knowing it's there. It's when your neighbor tells you that their child is having strange symptoms, you say, don't blow this off, go see a doctor. And maybe you tell the doctor about this disease called myositis. There are a lot of things we can do. One of the things that I think is super important is for, in our own ways, as we feel comfortable, for everybody to be involved in research as they can. And the reason we need this is because we just will not move forward without research. Research is what allows us to come up with new treatments, to recognize why people are at risk, to figure out what drug is the best drug for a person, all of these things. We need to understand what's called natural history. That's basically what happens when a person gets a disease. If you're a young person, if you're a 15-year-old who's presenting, how's it different than if you're a 55-year-old who's presenting? Clearly it's going to be different. We need to understand prognosis. This is one of the things that we most want to know, because when we sit down with a patient the first time, and especially because I'm a lung doctor, The question that I'm being asked is, am I going to need a lung transplant? Is this disease something that is going to progress to the point where I need to get a new lung? And I would like to be able to tell you the first time I see you, are you somebody who's going to be, we're going to be, saying this is not a big deal? Or are you somebody where we're going to need to start thinking about these things? We need to think of a better way of doing the diagnostic evaluation. I've just told you this is a rare disease. It's sometimes hard to recognize. We need something so that when you go into a doctor's office and you say, gee, doctor, I have this strange symptom, they can send a test that really clearly tells them what's wrong. And that's a big problem. I mean, it's a huge problem. A third of our patients don't have what we would recognize as being myositis antibodies. We know they have myositis, but they don't have the antibodies that we associate with it. And for a lot of patients, even if they do have the antibodies, nobody thought to send them. So we have a long way to go in terms of developing testing, making sure people know about the testing and that they send them. Treatment's a big issue. It's something we think about a lot. The medicines we use are not easy drugs to use. I'm sure all of you understand that. They have side effects. They can make people sick. They're very hard to get paid for by our insurance companies. So we need to know, if I could do one thing, if I could have a test or some approach where the day you walked into my office and I met you, I said, you're going to need this variety of medications. This is going to have a 90% chance of making you better. I don't want to use this drug because this drug only has a 50% chance of making you better. That's what we need. We need that personalized medicine to allow people to get onto the right medications the first time, not the third or fourth or fifth time. We want to understand genetic risk factors. Why do we want to do this? Because it will allow us to know which patient population should be screened. Let's say there are certain genes that we know put you at increased risk of having lung disease in myositis. Well, then every patient who presents with myositis should have a test for that gene so we can figure out, are you somebody who's likely to go on to get a problem with your lungs? The other thing that's really important is environmental risk factors. We know that there are probably things in the environment that increase the likelihood of developing myositis. Some of the things that we know are what you would call kind of experiments of nature. That is, people have gotten certain drugs, or have been around certain things and they've developed myositis, and so we know that increases the risk. But there are probably a lot more things out there that we don't know about. One of the things we think about in the Baltimore area is we have a nuclear power plant near us, and we have had a lot of patients from the area around the nuclear power plant. So we worry about whether there are other point sources in the environment that might be associated with increased risk. So those are the kind of things that we want to be actively engaged with, but we need our patients to be a part of that. So that's what I wanted to talk to you about. I'm happy to answer any questions you have. I'm happy to talk about any of the different topics we've talked about, but mostly I wanted to give you a chance to ask the questions that you wanted to ask, because that's what I'm doing here today. So thank you all for listening, and what can I answer for you? Yes, ma'am. Thank you.
I have a question for the diagnosing. When I kept getting tested, everything was coming back normal. But then my body collapsed, and my mom rushed me to the emergency room. They did blood work, and that's when my blood work actually showed something was wrong. And so they checked my CK level, and it was 20,000. And I couldn't move, I couldn't do anything. And so when the doctor came in, he said, what we're going to do is a deep tissue muscle biopsy, because I believe she has this very rare disease. And of course, everybody was like, what is it? He said we didn't know what it was. But due to the biopsy, that's what determined that I have polymyositis. So that's what I was going to ask you. You said you was wanting one good test that could, determine the diagnosis. So do you think that everybody that's kind of severe to do the deep tissue muscle biopsy, right. But is that the one thing that just you have to do?
So that's a really good question, and what you're pointing out is that sometimes the way you present, so you have that very high muscle enzyme. A lot of the patients I take care of don't ever have an elevated muscle enzyme. And so it might be appropriate for some patients to get a muscle biopsy, but for some patients it's just not going to tell them the answer. one of the things that's been a big step forward is the antibody testing. And I don't know if at some point in time you've had your antibodies tested.
I've never had them, but I did have a big situation.
Well, and that's a very good point. So I'm going to talk a little bit about that if you don't mind. So when I started off, one of the things that we had at Hopkins that made it easy for us to do this is we had a researcher who in the lab would test for antibodies for us. And there were antibodies, the only antibody we could test for commercially in the you know, if you send it off to Quest or whatever, was Jo1. And so everybody else who was not Jo1, who actually turned out to be the majority of my patients, majority of the patients who had lung disease, we couldn't tell them what they had. We would say, yeah, you have something autoimmune, we don't know exactly what it was. And then my colleague, Livia Casciola-Rosen, who's a very, very brilliant scientist, started testing for other antibodies. And she kept coming back and saying to us, you know, this patient has this other antibody, PL7, PL12, OJ, EJ, all these other ones. And so fortunately, at about that time, a couple of labs said, hey, we probably ought to start testing for these. And they set up tests. And it was like amazing. We were flooded with patients. They said, you know, oh yeah, this patient has this weird antibody, PL12, what is that? But finally, we could tell people what they had. Now, a third of my patients do not have an antibody we recognize. We send a lot of our antibodies to a very specialized research lab in Oklahoma, the Oklahoma Medical Research Foundation. And a third of our patients, they say, hey, we see that there are autoantibodies that your patient has, but we don't have a name for them. And so what we do is we say, you definitely have an autoantibody. We don't have a name for it yet. Wait another 5 years, we'll probably have a name for it. But that's the truth. We don't know everything. There's a lot of patients walking around who won't get diagnosed because they don't have that antibody name yet. And so it's one of the big gaps we have. Yes, ma'am?
How do antibodies get named?
That's a great question. So the way an antibody gets named is that a researcher spends a lot of time finding different people who have the same pattern of antibodies. So the way they do this is they take protein, they take cells. Actually, I'm sure you've probably heard of these cells. They take HeLa cells, and they get the protein from it, and they run it out on a gel, and then they lay the antibodies over it, and the antibodies recognize certain bands on that protein sheet, and they have different sizes. And so they start off with just having a size. They'll say, this is a 60 kilodalton protein or something like that. And then they'll see 5 or 6 or 10 or 100 patients who have that same pattern. And then they typically will go back to the first patient and they'll start to cut the bands out of the gel and try to figure out what protein did they come from. So originally, the Jo1 protein is actually named for the person who had the first antibody isolated. It's actually named, Jo is from the name of the person who got it. Much like HeLa is named for the person who provided those cells. Now we're increasingly naming the antibodies for the target. So if you have SRP, it's signal recognition protein. So now we're trying to name the antibodies to describe what they're actually attaching to. And I think that probably makes more sense than giving them these kind of strange names that don't really relate to what they do. So it's a big process, and it takes a lab that has the skills to do it, and it also takes a lot of funding for people to do this because these are very expensive experiments. And the reality is that we know only a fraction. There are probably more antibodies that affect people with myositis than the ones we currently know. And so I think that in the next 10 or 20 years, we'll be able to give a name to a lot of these antibodies, but only if the researchers are encouraged to kind of keep pursuing these and understanding that there's a reason why we want to know it, because nobody really wants to go around not knowing why it is that they have the disease that they have. Yes, ma'am. Oh, okay.
I may have missed this. How long did it take for you to gather the information to determine that the statistics in African or women of color was higher among the population? And how many took the, where did you gather the information?
So at Hopkins, we were very lucky, and now I guess about 12, 13 years ago, we developed a center, a myositis center. And at the time, we were told this was a super rare disease and we would be lucky to have anybody come to our clinic. And now, 13 years later, we have almost 15 people, 15 providers working in the clinic, and we cannot get in enough patients because there's so many people coming. And so what we did is when we very first started, we started collecting information. We would ask each of our patients when they came, would it be okay if we kept those demographics? And if we drew a tube of blood from you? And so we can try to learn more about this. And many, many patients participated, and I don't even remember the last update. I think we have over 4,000 people in our database at this point in time. But that's how we realized. And what we started to do was just to say, who is coming in the door? And would I expect to see that many people based on what the population is? And that's actually how we figured out that it was more common in African Americans than in white Americans. And it was also replicated in England in Africans living in the UK. And so we knew it wasn't just something that was specific to us. We knew once we seen it replicated in another country, we knew that this was probably a more general phenomenon, and it wasn't just by chance that we had seen that. And the reason, as I said, the reason that it never had come up before is because the places where they had mostly focused on myositis were areas where there were very small populations, either that really non-white populations, there were very few Hispanics and there were very few African Americans, very few Asians. And so really it had never been discovered because there weren't enough people to notice it.
So 13 years ago,
Yeah.
is when you started the
Yeah.
research and gathering the information.
Right. Yep.
My question is, I was diagnosed in 2007, but antibodies do change every day. So how often do we check, because I'm part of the research team also.
Yeah.
On the research. So do we check every time, like throughout the year, or is it something that you do, or do the patient have to get another muscle biopsy?
Oh, no.
To
No.
determine?
Yeah, so fortunately the antibodies are in your blood, and so certainly there are new things they can learn from the muscle biopsies, but most of the antibodies we actually measure in blood. And if your blood hadn't been sent to particularly to Oklahoma Medical Research Foundation, I would probably ask the doctor if that's possible. That's become available more recently. Not every institution can send, and so you would just have to talk to your doctor about whether they can send, and otherwise you might even talk to the folks at Oklahoma and just see if there's a way of getting the blood to them, because that's one of the things we still find is a problem, is that some of our patients, if they come with insurance that won't allow us to draw their blood, if they have to go to a local lab, we may not be able to send their samples out. And I mean, that's very frustrating because we know that we could get more information if we sent it to the research lab instead, and that's just not always agreeable with the insurance companies. But you can certainly talk to your doctor, and I think it's worth it. And the point you made is a good one. Sometimes people develop new antibodies over time, and I mean, we definitely see that in our patients where they came in and we thought we knew exactly what they had, and then we've been following people for 15 years now, and so some of the people who we took care of on day one, they've started to develop new things as they've gone through this process, and so we do recheck antibodies, particularly if there are new symptoms that pop up.
One more question.
Yes, ma'am.
PFT testing.
Yeah.
A roundabout estimate as far as, I think I get mine done like every 6 months.
Yeah.
But every 6 months because of the lung disease and sometimes cancer that can arise with myositis.
Yeah.
What profile do you work up?
Yeah.
Can CBC detect if something's going on?
Yeah, so there are a couple different things. So there are the antibody tests, which get done hopefully when you first get seen, and then maybe as repeated as needed, either because we've got new testing or because new symptoms show up. There are these things called PFTs, pulmonary function tests. That's how we measure your lung capacity Hopefully most patients got that the first time they were seen. If you have interstitial lung disease, we typically follow you every 3 to 4 months for 1 year. And if your numbers are perfectly stable, we might go out to every 6 months. If there's a drop in your lung function or we're treating you for your lung disease, we'll probably keep you on an every 3 to 4 month schedule. If you're somebody who's really sick, I might even have it repeated at 6 weeks if I'm worried about what's going on. Then there are other tests, the blood tests like a blood count, a complete blood count, a CBC, or a metabolic panel which checks the electrolytes. Those we check often, more often sometimes, especially if you're on a medicine. So like if you're on mycophenolate or you're on azathioprine or Cellcept or Imuran, you might get that checked, every couple of months because they want to make sure that the levels are good. If you're somebody who's taking tacrolimus, you might have to have it drawn, again, maybe even every couple of weeks if there's a question about it. So the testing frequency is really going to depend a lot on what your major symptoms are and what the treatments that you're on currently. But I would talk to your doctor about it. If there's a question about it, hey, I notice it's been a while since I had this done. The other thing I think I chatted with one of you about this is some patients develop a heart condition called pulmonary hypertension. We like to make sure our patients who have lung disease get an echocardiogram, which is a sound wave test of the heart, usually once a year. And so again, those are the kind of things you can go back to your doctor and say, hey, I heard about this thing. Do you think I need to have this study done? Yes, ma'am.
Yes, I understand that age that you talk about how only these myositis is found in women of color, particularly Black women and Latin American women. What about Indian women? I'm talking about women from India and Pakistan.
That's a great.
Women of color also.
Absolutely, you're absolutely right.
Has any myositis disease been seen in any of those women?
The answer is yes, and what I can tell you is that again, this is an issue of we in Baltimore do not have a very large Southeast Asian population. There is one in the Washington, D.C. area. We're increasingly seeing people come up from Washington to come be seen at Hopkins. But if there are other cities where that's more common, they will know the answer faster than we will. Because again, we had to see a certain number of patients to recognize what was going on. I can tell you I have been surprised by the very rapid rise in the number of patients who are coming from India and Pakistan who have myositis and have very severe myositis. And we've been trying to figure out, number one, why we're seeing them, and number two, why it seems to be such a severe disease. But we don't yet have that kind of number of patients to be able to make population estimates. So what we have to do is get enough so that we can say, does this make sense based on the number of people who are in our community that we're seeing this many patients with the disease? Yes, ma'am.
I understand. When we have this disease, one of the results of that, the body release, those of you who have, I know, I'll talk about polymyositis. The body releases too much TNF, and that's another factor that contributes to us, to PM patients having this disease. What is it?
Right. So one of the things that we try to do when we do research in these diseases is we'd like to figure out actually what makes people sick. Like when you get pneumonia, we want to figure out what bacteria do you have. When you have myositis, we want to figure out what kind of cytokines or the chemicals in the blood make you have the fevers if you get them, or make you have the sore joints if you get those, or make you have the skin rash if you get that. And so one of the things that's been identified is that for some patients, this thing called TNF, tumor necrosis factor, it's just named kind of, again, equally oddly like our antibodies, but TNF goes up in some people, and that seems to drive a lot of the disease. And so as a result, there's been a lot of interest whether TNF inhibitors, which are used in like rheumatoid arthritis for joint disease, whether they might be helpful. And what you'll see is that when you look at the medicines we use to treat patients with dermatomyositis or polymyositis or even inclusion body myositis, most of them were used for some other disease first. So rituximab, which we use, came from rheumatoid arthritis. Cellcept and Imuran came from leukemias and lymphomas, to tell you the truth. And so we use them because they have characteristics. They do things like decreasing TNF levels that we then say, hey, this may work in our patients. And one of the big issues that we're dealing with right now is we need to actually have very kind of careful clinical trials to figure out which drugs are the best and which ones have the least side effects. But those, again, is a research study, and it takes a lot of people and a lot of money. And so we're really working as a group, as an organization, the myositis community, to try to get those sorts of studies done so that, again, when you walk in, we can say, your probability is best on this drug rather than the other drug. And, that's a great example. Yes, ma'am.
So, a patient with myositis ILD, what does remission look like? A patient with myositis ILD, what does remission look like? Is it likely?
Yeah.
And do you see it?
Sure. So that's a really great question. So what a lot of people ask me is, what is it going to mean when I get better? What is that going to look like? Am I going to be like the person I was before? Am I going to be different? What's going to happen? So what I'll tell you is that, and how long is it going to happen? How long is it going to take before I feel like myself again? And there's a wide variation. So we definitely have some patients who we treat and they get better. It's really an incredible thing. It is unfortunately the minority of patients who get back to the place they were before they got sick. A lot of people will get better, but not quite as good as they were when they started. Some patients will level out at the level where we meet them. And so it may mean that if your lung function is diminished, that it always stays diminished, but it just doesn't drop off. And so it can be very variable. And because of that, we can't really tell you when you walk in the door, what is it that you're going to expect? I mean, for everybody, we hope that we're going to get them better. We hope we'll get them at least closer to where they were when they got sick. For a lot of patients, and I'm sure many of you have experienced this, you go through a bunch of different drugs. It's like, the first one didn't work, so we have to try the second one and the third one, and eventually maybe we'll get to one that actually really is the right one for you. That's, to me, probably the most frustrating thing, because if we knew up front which one was the right one to give you, that's the one we would give you. But at the moment, we still don't know how to figure out what's the right drug for the person. And so we do go through this. Like, I have some patients. I have a patient who I saw last week. We are now on drug 4 for her. But we're going to keep going until we run out of choices because she's not getting better. And that's what we're trying to aim for.
And my second question is, what do you think about antifibrotic agents, and do you utilize any of those in your patients?
So this is something that is kind of an interesting topic. I'm going to tell you exactly. Yeah, there are drugs called antifibrotic agents, which are used for a different kind of lung disease called idiopathic pulmonary fibrosis. That's actually a fibrosis that happens in older people. It's a disease of aging, much more common in white men. Essentially never happens in women. Essentially never happens in blacks, which is quite interesting. But there were a group of 2 drugs that were approved for idiopathic pulmonary fibrosis that seem to block this process of going from inflamed lung to scarred lung or fibrosed lung. And right now they're in clinical trial. They just finished a clinical trial in scleroderma-associated ILD, and there's a trial that'll be resulted next month in other types that will include patients who have myositis. And so what I can tell you is in the scleroderma trial, there was it was a statistically significant but small difference for people who were taking an antifibrotic on top of their immunosuppressant medicine. But an immunosuppressant was better than an antifibrotic alone. An immunosuppressant alone was better than an antifibrotic alone, but if you put the 2 of them together, it was just slightly better, okay? So at this point in time, I would not give an antifibrotic to a patient with myositis, only because the data's not in. Once we see the results from the trial that's coming in, I would probably think about it, but I would only do it after we've done all the things we know will tend to help people. I wouldn't use it as a first-line agent. These are very expensive drugs. Not that all the drugs aren't really expensive. These are very expensive drugs, and they have significant side effects. And so I really want to be sure that I'm only giving it to somebody where it's going to make them better and it's not going to have more side effects than it has benefit.
My question is, I have ILD, but it's now, okay, so I got diagnosed with ILD in 2008, and then just now in 2014, I was diagnosed with pulmonary hypertension.
Yeah.
So I just want to know, I know that lung transplant is probably what most likely in my future, but I just want to know, with someone in my situation, do you just only get the lung transplant, or am I going to have to get a heart transplant combo or thing like that, since it is affecting my heart problem?
Yeah. So, your local transplant people will talk to you about this, but it turns out that, so sometimes if you have lung disease, because the lung and the heart are so intimately related with each other, the heart gets under strain, and when the heart gets under strain, it can cause this condition called pulmonary hypertension. And what that is the part of the heart that pumps into the lungs gets kind of overloaded. It doesn't have enough strength to push against the resistance from the lung. And then the right part of the heart just gets bigger and doesn't work properly. And there are medicines that are specifically for pulmonary hypertension. One of the reasons we want to identify patients who have pulmonary hypertension is there are great drugs for treating pulmonary hypertension. And that we know those drugs improve people's ability to walk, it improves their survival, it improves their quality of life. So we want to find it because we want to treat it. And then sometimes if that isn't enough, people go on to get a lung transplant. And when that happens, the heart suddenly has this huge relief. It suddenly doesn't have to pump into this lung that's been causing all this resistance. And so for a lot of people, their heart actually remodels. It actually starts to work better. Some people, it's hard, and pulmonary hypertension is one of those things where it's very variable for different people. And so sometimes people have to use some added medications after transplant to help the heart still work well. But generally, we're not doing a heart-lung in those patients. Most of the time, just replacing the lungs is sufficient. But again, a lot of that's going to depend on your personal situation, and I would definitely encourage you to talk with your transplant. One of the things I was saying, and I don't know if anybody else is in a situation where they've talked about transplant or thought about transplant, but please start early to go through the transplant process, because the only thing that's really upsetting is to not know the answer and to get so sick that you can't get to a point of transplant. So even if you go through the process and you decide you're not going to be transplanted, it's better to know than not to have the opportunity to know. So I really like people to try to get in as early as possible. And our transplant programs are certainly saying that as soon as we're starting to see people who have pulmonary hypertension, they should be going to transplant. They should be getting evaluated. I am being told I have 5 minutes left. Yes, ma'am.
What are the symptoms of
pulmonary hypertension?
Yes.
Yeah, so it can be really insidious. It's a lot like lung disease, the interstitial lung disease, is that often people just notice they're short of breath. And when you have interstitial lung disease, you're short of breath. And some people cough with it, which is very similar to interstitial lung disease. The thing that when it gets more serious, sometimes people feel lightheaded or faint when they exercise or when they walk around. And sometimes they'll find that their heart rate gets very high when they develop pulmonary hypertension. But it can be as subtle as just when they're doing those breathing tests, that diffusing capacity number, it starts to go down. And that's when we start to look for it. As soon as that diffusing capacity starts to go down, that's where we're worried about it. Yeah.
I have one question. It might be awful. But I just want to ask this question. I think this is for all of us. But when I think about myositis and the other diseases that's connected with it, have we ever done anything, because everything goes into the bloodstream and the overload of toxins in your body from the medication, have we ever done anything to try to cleanse the blood over a period of time for the patient?
Well, it's a great question. And so for centuries, we've tried to figure out what are the signals in the blood that are telling the organs that there's something wrong. I hope none of you have had this experience, but sometimes when people come in with very severe myositis, or we can't get it to go away with the muscles, we actually do something called plasmapheresis, which is where we take all their blood out and we suction out basically their antibodies, and then we give them clean antibodies back. That's the closest we get to it. You're pointing to a fundamental question, which is, what is the signal that's causing this? And that's what we're all really trying to get at in our own ways. What is it, the signal that's causing the lung to be damaged? What's the signal that's causing the muscle to be damaged? What's the signal that's causing the skin to be damaged? We're still trying to hone in on that, because if we could figure out what is that message, we could make a medication that affected that, just that one thing. And so we use these immunosuppressants, but that's sort of, I often give the example, it's a lot like using birdshot, and what we really want is a sniper rifle. We want to have something that just affects the one thing we're looking at, not scattering and having all these other effects. But that's what we're trying to do our research on. And again, if I can just leave you with one message, you must be your own advocate, okay? You need to search out information, educate your doctors, look for other sources of information if your doctor doesn't have it, and please, please, please consider being involved in research, because if you're not involved in research, we just don't know how to move the field forward. So I'm happy to answer any questions for anybody who has them remaining, but I will finish on time, so Dale doesn't have to hit me. Thank you very much for being here.